So this, and again, actually, so the conference this year was in Montreal, and this was the first proper face-to-face conference. It was both face-to-face and online. Gus was joining it from London, and I was in Montreal. And I think certainly for me, one of the things about being there was, so the first in-person one since COVID, obviously, the sense of like getting people together, and people were really taking the opportunity to protest. I think there were more protests at this conference than any I can imagine. And just to give you a flavor of the kind of things that people making a noise about, top left, that was about the response to monkeypox, and particularly about equity in access to monkeypox vaccines in different parts of the world, and in particular within countries. The bottom left was a protest about rumors around the price of injectable PrEP in lower middle income countries. Gus is going to talk about that a bit later. Top right was about people still dying of advanced HIV, and basically a sense that deaths from AIDS, deaths from advanced HIV are still occurring. There's not enough of the HIV response is actually focused on that. I mean, clearly it's a particular problem in Africa and Asia, tuberculosis, cryptococcal meningitis, and just a lack of attention to that. And the one at the bottom right was very much about the whole visa issue, and you might have picked up on this problem of the International AIDS Society decided to hold the conference in Canada, a high-income country that has, is it a particularly, well, it seemed to be particularly problematic, its policy about issuing visas to conference delegates this year. And Alex, if you advance the slides, you know, what this kind of, it really has an impact on the kind of discussions that are being had. And when so much of HIV is happening in poorer parts of the world, but the people who can actually get to the meeting to discuss it, have not overwhelmingly come from richer parts of the world, but there's definitely a bias. You know, there was, when I saw that people were joining, when speakers were joining virtually, it was usually either because they were so important and busy that they didn't want to take the time out, or more often because they were from African countries and hadn't got a visa. And there was even like one panel discussion where all 5 speakers had to plug in virtually because they'd all been refused visas. And it really does, I mean, I would think it's affected every conference over the years, but there was a real light put on that at this one. If you move on, Alex. Another topic there was a protest about, I've got to say this one slightly perplexed me. There was a big U=U protest, and half of me was thinking, who are they protesting to? Who are they angry with? Because it was very much preaching to the converted in that conference. But I guess the other half of me was thinking, they were basically saying, why are so many people still unaware of U=U? And I mean, the example on the slide was of a big survey in Southeast Asia, you know, but you can see similar patterns wherever you do a survey around the world, that enormous numbers of HIV negative gay and bisexual men are unaware of U=U. I mean, you go into the general population, it's obviously going to be much worse even. And then still significant numbers of people living with HIV who still haven't been told about U=U. in particular by their healthcare providers. We move on, Alex. There was a kind of a day-long, or was it even 2 day long pre-meeting about U equals U, and particularly about communicating that in healthcare settings with examples of good practice. I mean, THT Can't Pass It On was definitely cited as an example of good practice. And at the bottom of that slide where it talks about the online training modules, that's something that I think that's HIV Prevention England have done, if I'm not wrong, Alex. But there were lots of discussions about where this is working, where this is not working. And actually that point there about zero risk was quite interesting. So this was a Canadian researchers who tried talking to doctors, nurses, other healthcare professionals in Canada about how they discussed U equals U, and a lot of them really coming up against a barrier of saying, we don't like to say anything is zero risk. We're taught in medical school that nothing is zero risk. You can't be so definitive. And I'm not entirely convinced that in that example, they had really found a way around that. We move on, Alex. And then a whole bunch of different examples from around the world. I mean, so that first one of, over half of people living with HIV in the global south not understanding it, or not having been told the meaning of the term undetectable viral load. But some examples of good practice in Latin America, and at the same time, kind of like fundamental underlying issues in the Caribbean or the Middle East that are affecting understanding and uptake of new health information. I mean, this message the same as other ones. And yeah, if you have time to go and follow some of those sessions at the conference, it can be quite interesting, seeing the examples of good practice, seeing the way activism in countries like Turkey has been key in raising awareness. And the Prevention Access Campaign, who are kind of behind the U equals U movement, were very keen on this new guidance from PEPFAR, which is the US development program for HIV in mostly African countries, which is now putting U equals U messaging in a lot of its guidance. If we can move on. Oh, and at this point, I pass over to Gus, who takes over.
Okay, great. A risk of sort of trespassing on Roger's territory. The formulation I most liked about the zero risk thing was was Anthony Fauci's, a man who I'm sure is feeling very relieved tonight at the election results in the States, who basically said that the chance of getting HIV from somebody with an undetectable viral load was statistically indistinguishable from zero. And if somebody says, what does that mean? You say, well, 120,000 instances of sex, and we didn't spot a single transmission from somebody with a viral load under 200, and that's all you can say. So, so introductory long-acting PrEP. Now, a long-acting treatment, which I think we're going to look at later, has been around for some time and is now, I'm starting to hear of people who are using it in Europe as well as in the States. But long-acting PrEP has much more potential to be a real game changer, partially, well, because the randomized controlled trials of long-acting PrEP, which is an injection of a single drug every 3 months, cabotegravir, at the moment. There may be other formulations later on. The randomized control trials of this as the way of taking PrEP, they measured the efficacy of it against standard oral PrEP, and it was astoundingly more effective. I think in gay men and trans women, it was 69% better at preventing HIV than standard oral PrEP, and amongst cisgender heterosexual women in Southern Africa, it was 90% more effective, which I think is a remarkable result, really. So it's not just that it has a sort of somewhat better performance than oral PrEP. It's that whole populations who up till now, for one reason or another, have either not used PrEP or haven't been able to use it efficiently, could use it. And that could make a really big difference to HIV infection rates in different countries. We don't even have enough people using oral PrEP, as it says here with this slide. It was just 28% of the target of 3 million people in low and middle income countries. But that may well be because daily PrEP is not that feasible for everybody. It's a very different thing, I know from personal experience, taking a preventative drug that might just stop you catching something from one you actually really need in order to stay healthy. And also, PrEP users may be younger, more mobile, know less about HIV than people who are on treatment. So for all these reasons, and for reasons to do with stigma, a lot of people, especially women, have cited being presumed to be HIV positive as one reason they wouldn't want to take oral PrEP or have the pills around the place. So next slide, please. So this is all part of what I think Jim Pickett in the USA calls the choice agenda, which is an agenda whereby we expand the choices people have about HIV prevention. When PrEP came along, it was, of course, an expansion of that. Previous to that, we'd only really had condoms and the knowledge of HIV, of U equals U, was just starting to spread. We also have the vaginal ring. And one of the interesting questions that people were asking, and I think they were asking probably at the conference, is how come this has been licensed in Africa and not in the higher income world? It's a very interesting question. The history of the dapivirine vaginal ring is that the randomized control trials of that only showed that it was about 30% effective, so not great news. But open label studies that have gone on have shown that it can be a lot more effective than that if it's used by women who want to use it and use it regularly. Right. It is not as effective as oral or injectable PrEP, but on the other hand, if it's the one thing that women are going to use, then it should be on the menu, I think, of prevention modalities. I did see at the recent Glasgow conference an argument that, well, okay, but if the idea that this is the most you can get out of PrEP in terms of being 30 to 60% effective is something people also think about the pills and injections, and that's a bad thing. So we need to handle it carefully. But I do think that the argument for making the vaginal ring and ongoing studies are being done of combining it, for instance, with a contraceptive ring, with an anti-STI ring, of which more later, means that there's really no reason why it shouldn't be licensed as a choice in higher income countries as well. Of course, in somewhere like the UK that has an NHS, cost inevitably creeps into this. But it does seem very odd that it's only licensed in Africa. Next slide. So I like doing cost effectiveness studies. Sheena McCormack, the wonderful scientist, once flattered me by saying, "Oh, you know more about cost effectiveness than I do, Gus." Anyway, but the point about cost effectiveness studies is that they are influential because politicians and finance ministers listen to them. So how much cheaper would injectable PrEP have to be for it to be cost effective in a Southern African context, right? Because at the moment it is extremely expensive. We are talking about thousands and thousands of pounds, as much as in almost as much as injectable HIV treatment. So they did a model based on the South African epidemic on how much this thing would have to cost in order for it to be to save lives for a reasonable cost, which is what cost effectiveness studies do. They say, okay, let's look at the number of infections and of years of poor health and of deaths this thing might prevent. And then let's see how much it costs per life saved. That's what they do. And so what they found was, next slide, please. Okay. The rather pretty curve on the right is just sort of different scenarios. Do you offer it to lots of people? Do you offer it to people maybe only at the very highest risk? Do you offer it for a short time or for a longer time, all that sort of thing. But really, it sort of came out as pretty similar. So if long-acting cabotegravir costs the same as oral PrEP in a Southern African context, and they put that at about £80 a year, it would be more cost effective if people used it for a shorter period of time. If it cost less than £80 a year, if it cost double that, which is twice the price of oral PrEP, it would be marginally over the cost effectiveness threshold, which means that countries would be reluctant to pay for it. To be cost effective at high coverage, meaning lots of people taking it, it would need to cost less than £9 an injection. And that is at least 2 orders of magnitude less than it costs in the USA. So, we're talking about at least 100 times that. So these inequality differentials are really fierce. Nonetheless, next slide. I think this study contributed to the pressure that was being exerted on the drug company ViiV that makes injectable cabotegravir. And having initially said that it was much too complicated and difficult to make, they changed their minds and said, we will license 5 generic companies. Didn't say that here, but I think they agreed that later on, to make long-acting cabotegravir under a license from us so that we assure quality, and so that it can be distributed to the 14 PEPFAR countries that are generally the countries in the world with the highest HIV prevalence, the highest HIV burden. As it points out in this slide, that doesn't include a lot of countries with considerable HIV problems, but it is a start. Since then, there's been considerable pressure has been exerted in Europe on ViiV to start the process of making it licensed in Europe, and they've recently started the process of submitting it to the European Medicines Agency. And Zimbabwe and South Africa have now licensed it. And South Africa has written up a plan for introducing it. So I think we will start to see long-acting PrEP being given out to people in Southern Africa early-ish next year. Okay, I think that's, yes, are we having a break now, or are we? Yes, we are. Oh, no, we're not. We're going on to...
No break.
That's very, very important. Forgot all about that. Okay, so probably the first presentation I covered at the conference. STIs, by which we mean the bacterial STIs, syphilis, chlamydia, gonorrhea, at very, very high rates amongst people vulnerable to HIV, both among young women in lower income countries, among gay and bisexual men everywhere. And although, they're curable, unlike HIV, you don't have to take medication for life. They can be very nasty, particularly syphilis. In women, chlamydia and gonorrhea are particularly associated with infertility. So these are things you don't want. Now, could you combine PEP or PrEP for HIV with something else, so you could stop people catching STIs as well? And so they did precisely that. They compared giving nothing versus giving doxycycline, an antibiotic that's widely used, but not currently really used specifically as an STI treatment unless people have things like allergies. You may have come across doxycycline. I certainly have, as a prophylaxis against malaria. I've taken it when I've gone to tropical countries. So it's a very well-established drug. It's very cheap and it's relatively lacking in side effects. This was PEP. There have been other studies of doxycycline used as PrEP, in other words, in advance of sex, but this is if you've had sex and you're worried that you might have exposed yourself to an STI, to take it as soon as possible and no more than 3 days after condomless sex. And of course, if you are HIV negative and on HIV PrEP already, you can combine the two. And what happened was, is there a follow-on slide? I can't remember for the results. Yes. The incidence of gonorrhea, chlamydia, and syphilis went down. In the case of syphilis and chlamydia, considerably. I mean, they've lumped this together as a 66% decrease, but in fact, it was more like 80%, 85% in chlamydia and syphilis, which is really good news. It was less in gonorrhea. About 56%. And in the previous French study of using this as PrEP, it had no effect on gonorrhea. This is because the gonorrhea bug acquires resistance to drugs very easily, whereas it doesn't against the other two. And so this is a very promising result. And there has been news since, I hope Roger won't mind me giving news since, which is that a study presented at Glasgow, actually, it wasn't even a study, it was a piece of news, a French study which combined this idea of doxycycline PEP, I think it was, with a vaccine against gonorrhea, because we have a candidate vaccine against gonorrhea, had such good results that the study was stopped. And we don't know what those results are. I think they're likely to be presented at the CROI conference in February at the earliest. But this is potentially very good news. There are all sorts of controversies around this. Oh dear, giving antibiotics all about, you know, you're going to encourage resistance. And I do think that there is some a reason to that argument, specifically when it comes to gonorrhea. But nonetheless, this is very promising because, you know, the more things we have to ensure people have good sexual health, the better. Okay, now it is time for some sort of, no, that's, beg your pardon, I've got one more slide. Yeah, that talks about resistance in gonorrhea. And so it shows that basically resistance, and particularly, you know, significant resistance in the red bars, went up in the gonorrhea that people caught despite PEP. So yes, this is a potential problem, but if we can combine that with a vaccine, we might be getting somewhere.
That's great. Do drop any questions into the chat that you have. I guess I'll start, guys. What was, in terms of the Doxy-PEP, was there, you know, that debate at the conference around resistance and what that tells us? And what do we know? You know, you mentioned, you know, it's a drug that's already used elsewhere, that it must be used by millions of people already. Is there anything we can learn from how it's used in other conditions as to what the impact of that resistance might be? Like, is that an issue, you know, for example, using it for malaria?
Well, I think people tend to, I mean, there is this myth that sort of, if you just give people antibiotics too much, then they're all going to get drug resistance to absolutely everything. And that's not the way it works. It's much more sort of fine-grained than that, as it were. If you only give this particular drug as prevention and you do not use it for treatment, and you have very strict guidelines saying you must not use this drug for treatment, then there is less chance, because the whole point about resistance is that it is generally acquired where you take not enough drug while you already have a bug. So resistance is less likely to arise, and this was a question for HIV PrEP too, when you're taking it to stop a bug getting inside you in the first place. Okay, it can happen if you have unsuspected infection and you take antibiotic or not enough antibiotic, which is the point on top of that. But in addition, doxycycline and its entire class, the tetracyclines, is now not used as STI prophylaxis, as STI treatment, beg your pardon, because there's too much resistance. And so it still works very well against syphilis, though there are cases of syphilis with resistance to it, and chlamydia. With gonorrhea, I think we are currently, it's certainly European and US guidelines, restrict gonorrhea treatment very specifically to one specific drug, ceftriaxone. And if you're allergic to that, then to another drug, azithromycin. Those are antibiotics, neither of which belong to the same class as doxycycline. So in theory, you shouldn't see any more doxycycline resistance than you already do. But in gonorrhea, that can be quite high. And in some populations, like we already saw in France, that means it doesn't work against gonorrhea. It will work against the other two. But the gonorrhea vaccine is interesting because it was more or less picked up by accident. I think somebody said, oh, the gonorrhea bug is a little bit like one of the meningitis B bug that causes meningitis, and we have a vaccine for that already, so why don't we try it for gonorrhea? And they found that it was moderately effective, but up till now I've only seen it being about 30% effective. So if they found it was more effective than that, or if they were using a different tweak of the same vaccine in the French study, then that is seriously good news.
Yeah, it's really interesting and definitely an area that everyone has their eye on. A couple of comments and questions that come through. Mina just mentioning around how the ring would allow more discretion for women rather than the tablet, and a question from Stephen around the effectiveness of injectable PrEP versus oral PrEP, and whether that's down to human error or if it's because injectable PrEP itself is more effective as a compound, I guess.
Okay, it's great questions. I don't know if you want to say anything, Roger.
I mean, I think the one particularly about injectable PrEP, you've probably got the better answer ready. So
I mean, the first thing about vaginal ring being more easy to conceal than oral PrEP, absolutely, yes, that's exactly the reason. But some women may prefer to use it. I gather that some men can sense it, as it were. Yeah, and I mean, this has always been a problem with oral PrEP. Because in the Southern Africa, people live in multi-occupancy, little small houses. It's very little privacy in the way that we have it here. There are mobile populations, people who may not be sleeping in the same place every day, all that sort of thing. It just makes it really difficult. And that goes on to the injectable thing. Yes, there's no evidence that injectable PrEP in itself is more biologically efficacious than taking a pill a day, or even just a pill on the 2-1-1 protocol, where you take 2 in advance and 1 each day afterwards. No, it's probably, it's almost certainly not more biologically effective. In fact, there's even a question around cabotegravir that it might be very slightly, and I emphasize very slightly, less biologically effective. The difference is driven entirely by adherence. It's really easy to forget taking a pill once a day for 3 months, just on the day or the couple of days when you happen to meet someone and have sex with them. If you have an injection, you don't have to remember to take it. It's as simple as that, I think. And as long as you actually remember to go back to your clinic appointment, and adherence to clinic appointments was very, very good, not just in the randomized control studies, but in open label studies I've seen, then you are protected for that period of time.
That's great, thanks. I think for time we'll move on to the next section.
Yeah. Okay. So that's
you, Roger, thanks.
Yes. Okay. So there was, a little bit of data on oral PrEP in pregnancy, and obviously that's a kind of key question which has not been particularly well studied, as is unfortunately typical, that issues about the safety and effectiveness of medication in pregnancy, we often get the data much later. So this study, I think it's very early data at this stage, but I guess the question that the researchers here are trying to look at is, okay, if women take PrEP during pregnancy, is there any difference in the first 5 years of life for their children compared with children whose mothers didn't take PrEP during pregnancy? And the kind of things they're looking at are, I think, preterm birth, but certainly weight, height, and all kinds of measures of neurodevelopmental outcomes. So kind of language learning, cognitive function, things like that. At the moment, there's only 664 mothers and children in the study, and fewer than 1 in 5 of the mothers took oral PrEP. But next slide. Yeah, for the moment, there are no problems to report. On that slide, you can see the things on weight and height or length, as it were, and there's absolutely no difference between the kids who were exposed to PrEP inside the womb and those who were not. And for the neurodevelopmental ones, there wasn't any difference either. So that study is going to carry on. At the moment, there you've got data up to 36 months at 3 years, and they're going to follow these kids up to 5 years, and they'll obviously be getting more mothers and kids in this study. So something to keep an eye on. Next one, please. Weight gain. There weren't many HIV treatment studies which we felt were really directly relevant to the UK, but obviously weight gain is something that people continue to ask about, and we're kind of getting more clarity on. This is updated data from really one of the key studies that sort of seem to shed light on particular drugs. Well, is it that particular drugs are causing weight gain, or is it that other drugs are causing suppression of weight, and therefore the difference is you see that when those drugs are taken away, and that is possibly part of what's happening here. So there's updated data here. So this is from about 3.5 years, and this was a randomized study. So there's lots of problems that you have when you do like sort of a real life observational study, whereas the randomized one is more, you can be pretty certain that this is something to do with the drugs here. So if you go on to the next slide. Okay, what you can see here is this is the extra weight that was gained over time. And the 3 different colored lines are 3 different drug regimens. 0 is when people started on these drugs, and I'm pretty sure this was starting treatment for the first time, if I'm right, rather than switching, and how that evolved over time. So I think maybe the top line, the blue line, is the combination of drugs that seems to be most strongly associated with weight gain. So that is TAF, which is the newer version of tenofovir, that you're only really likely to be taking that if you are on a single drug once a day regimen. Actually, you could be on a 2 drug a day regimen, but it's something that Gilead, the drug company, have been trying to push. I think a lot of the clinicians are quite rightly a little bit skeptical about its value, and that in combination with FTC. All the combinations here are FTC, which is N-tricitabine, and dolutegravir. So dolutegravir is the integrase inhibitor that is very widely favored as the best thing to start with, but has been associated with weight gain. So that blue line, you can see there's quite a rapid gain of weight in the first 48 weeks, so roughly the first year. And then it does continue to increase, but maybe not as fast. And then the orange line, you take out the newer version of tenofovir called TAF, and you replace it with the older one, the one that we've been using for longer, called TDF. And you see that the weight gain is less, but there's still dolutegravir is still in the regimen. And then on the green line is a very much older drug. So you've still got the older form of tenofovir and efavirenz, which is a drug that lots of people, particularly in the places like the UK, have stopped taking because it has got problems with difficult dreams, various sense of dizziness, all kinds of sort of side effects to do with to the mind. And there is basically a theory, which is that what's really going on here is that some of those older drugs, particularly with TDF and efavirenz, are actually associated with weight suppression. So people gain less weight than they would have naturally done if they weren't taking any medication. I mean, that is all to be proven. Next slide, Alex. And that summarizes some of the data. So you can actually see like how many kilos people are putting on, and in particular that highlights that this is a problem that specifically affects women more than men. That study was done in Southern Africa, so I think virtually every participant was Black, but in studies which include both Black and white people, there's a stronger effect for Black people too. And next slide. So yeah, this summarizes some of what we kind of think about the risk factors. So on that graphic, you can see in the middle what I was trying to explain there about different types of drugs. So integrase inhibitors such as dolutegravir and TAF being associated with weight gain, whereas TDF, the older tenofovir, and efavirenz with weight loss. And then other things that are probably going on there. So that's what's called return to health effect. So if you've been quite unwell and you start taking antiretrovirals and you start to feel a lot better, your immune system gets better, you've got less virus, then that tends to promote weight gain. And then there's a whole bunch of demographic issues on the right, which are clearly not affected by starting treatment, but are clearly part of the reason, as part of the whole holistic understanding of why people are putting on weight or not. And let's move on. So we talked a little bit before about injectable PrEP, and there was also a lot of discussion about injectable antiretrovirals. So this is cabotegravir and rilpivirine, which are just starting to be introduced in the UK and similar countries. And so some of the points here very much reflect what's, I think anyone here who's working around treatment here will be kind of familiar with some of these points, but that were very much being discussed at the conference. So, you know, the whole benefit of injections as being discreet for people who find daily dosing problematic, for people who find taking a pill every day and that sort of routine quite difficult. But at the same time, there's a recognition of barriers. You know, for some people, it's more of a problem to need to come into a clinic once every 2 months than it is to take a pill every day. Some people do get a sort of painful feeling where the injection has gone in, like where it's gone in the bum. that tends to improve. People tend to find the first few injections worse than the ones that later on. So basically people get used to it. And of course, there are sometimes drug interactions as with any medication. And if somebody has a problem with the medication, which is pretty rare, but you can't just take it out of the body. Like if you're on a daily medication and you realize it's a problem, you just stop taking it, and within a few days the drug will be out of the system. But by its design, this drug stays in the body for weeks and months, ongoing. And just thinking about sort of whole costs for the health system, I mean, expected to have fewer people failing treatment, partly because you can, that sort of ability to know whether people have taken medication and put measures into place to get people back into clinic. So resulting in less costs for people getting unwell. But at the same time, health services are going to have to pay for training staff to do these injections. The medication itself costs more. And one of the drugs, the rilpivirine, needs to be kept in a fridge. And actually, I'd add to what's on the slide there. I think the admin cost of having systems in place to track who's come back for an injection and calling people back. Next slide. There's groups of people who are most likely to benefit, but strangely, the studies haven't really been done in these people. So there is a bit of an ongoing issue that, I mean, I suppose this is fairly classic. The drug company sets up a study to prove that their new product is going to work, and they start with the lowest hanging fruit. So with injectable cabotegravir or rilpivirine, people who have already got an undetectable viral load that therefore have been shown to adhere to medication, they're generally relatively young or middle-aged without too many other health issues. Whereas actually, it may be that the kind of people who are most likely to benefit will be in more challenging circumstances. The studies haven't really been done. And even, do we know, there's lots of speculation. Oh, this would be great for homeless people. Is someone on, someone's not on mute? Not on mute.
This is very unhealthy.
Thanks, thank you. So yeah, for example, the speculation that this would be a good option for homeless people. Has anyone actually done some studies with homeless people checking that that's what they would like, or trying the drugs out in that group? Not much. And in particular, I think there's the big question about drugs work well in people who are not currently virally suppressed. So people who've had real problems with daily oral medication. There was actually one poster at the conference from San Francisco where they were trying that, and with very, very small numbers, it was quite promising. But we need a lot more than that. Can we move on to the next slide? So this wasn't really brand new data, but we've identified what there are certain risk factors for this treatment not working, and they are specifically pre-existing resistance to rilpivirine, which is a NNRTI. There's this subtype called A6A1, which is much more common in people from Russia. So there's not a lot of people with that subtype in the UK, but particularly with what's happening in Ukraine, there are some people, and a high body mass index. So that's the level that's considered clinical obesity. And was also discussed at the conference was whether it's necessary to take a month's worth of pills before starting the injections, which is how they were initially studied. And the is still for that to happen as an option. And this data there is just basically showing very similar results for who did start with a month's worth of pills. Who did not, in fact, yeah, that's showing better results for people who went straight to the injection, what they call DTI, direct to inject. So that makes it simpler to implement. Next slide. And this is data from a European survey, which is, I think, reflecting what many of you, I'm imagining, have encountered with people you work with, that there's a lot of enthusiasm out there. In treatment, not for everyone, but, you know, kind of key factors, pill fatigue, not liking daily adherence, wanting to be, you know, the whole issue, as for with PrEP, about having HIV tablets in the house and a daily reminder of HIV. But the ability of this is the big problem, and that's going to be a problem in the NHS as well, I think. Next slide, and I think that might be for Gus. Yes, that's Gus.
Yep. Okay, I'm going to sort of speed through this. So we've got, I've just magnified the chat, so I can't see the slides. There we are. Okay, so I'm going to speed through this because I want to allow some time at the end for questions. Really back to the sort of equality agenda and where we're going with the global AIDS epidemic at large. UNAIDS released probably the most pessimistic of their global HIV state of the epidemic summaries that I've seen. It was called In Danger before the conference. Massive, great document. No region so far, you know what the 90 targets are. In other words, 90% of people tested, 90% of them in care, 90% of them undetectable. That adds up to 73% of people with HIV, including those who don't know it, undetectable, which is the sort of target you need. And 95 is obvious. I can't remember what it adds up to, but it's more than that, 89% or something. Okay. Now, what UNAIDS is very concerned by is that, interestingly, apart from Africa, which has had lots of money thrown at it, we seem to be stalling and even going backwards in certain areas in terms of these targets. Now, the slide is probably a bit too small to see, but if you go along to the 1, 2, 3, 4, 5th column and the 7th column, the blue there is the proportion of people who are tested. The middle is the proportion of people on treatment who are tested, who are diagnosed, and the grey is the proportion of people on treatment who are virally suppressed. You'll see that those aren't doing so well, those columns. And the 1, 2, 3, 4, 5, 5th column along is Eastern Europe and Central Asia, right on our doorstep, in other words. And the 7th column along is the Middle East and North Africa. Middle East and North Africa historically has been a low prevalence area for HIV, but the point is that if it keeps on creeping up there as it is, it will eventually not be a low prevalence area for HIV. And interestingly, places like Egypt are places that have very high levels of other bloodborne viruses like hepatitis B. So who knows but what's going to happen there. Meanwhile, we all know what's happening in Eastern Europe. It was already a disaster zone in Russia in terms of the effectiveness of their HIV programs. You know, everybody's worried about the situation for Ukrainian refugees, people like that. And also, of course, the impact of the war on things like prices, including medication. Lots of people who don't know how to navigate healthcare systems coming into Western Europe or into Central Europe. There was a very good presentation at Glasgow by a Polish doctor about that. So lots of concern. And as well as Eastern Europe and Middle East, North Africa, Latin America, which is the sixth column along, is more or less standing still in terms of annual number of diagnoses of people with HIV. And alarmingly, one country in East Asia, the Philippines, has started to see an increase in incidence in new diagnoses as of the last year. They are in a country with particularly punitive laws against people who inject drugs and so on. So they're a bit worrying. Next slide, please. So UNAIDS also have picked up on the fact that in many ways, community-run organizations actually deliver better HIV services than large medical establishments. Not everything, but things like both the COVID epidemic and what's going on in Ukraine at the moment have shown that small community-led organizations that are nimble and are trained up to do things like testing and diagnosis and referral for PrEP and things like that can actually do a better job. Even if they are not themselves people who can prescribe, they can certainly do the assessment and the referral and the counseling. And so they want to set up a new standard, 30-80-60, saying that community organizations by 2025 should be doing 30% of testing and treatment services. Interesting, that contains treatment. 80% of HIV prevention services, because of course they already do a lot of them, but that means things like PrEP referral and injection referral and things like that. 60%, oh God, I hate UNAIDS language sometimes, of programs to support the achievements of societal enablers. Now, what that means is things like advocacy for people who get into trouble with law because they're sex workers or drug users. It means kind of mental health support. It means education. It means everything else that may act as a facilitator of HIV. Okay, next slide, please. And so, I mean, I think in a way, these points are sort of obvious. Legal reform is happening, but too slowly. One thing I wanted to add to the visa story in Canada is that it's not just people who from poor countries who rich countries think might want to settle as it's also in smaller numbers, but it's an ongoing problem. A lot of people with HIV have criminal convictions as former or current sex workers, former or current drug users, for instance, and they are also a group that finds it very difficult to get into HIV, into countries where HIV conferences are happening. Stigma and discrimination still block the way forward, obviously. Interestingly, after this and during the conference, certainly PEPFAR announced, I haven't got the figures here, Roger, certainly an increase in the amount of money, and so did the Global Fund. So I think they may have been, they may have seen this and got and think, okay, well, we better start putting a bit more money into the global HIV push against HIV. Okay, so next slide. And I've got 3 minutes because I'm giving myself till 7 to talk about cures. Everybody loves a good HIV cure, but we're still a long way off. But there are now 5 people who are officially designated as having been cured of HIV, and we had a new one announced at Montreal, the City of Hope patient, named after the cancer center where he was treated. As with others, it was a stem cell transplant for a patient who already had a blood cancer, leukemia in this case, and they took the opportunity to give the transplant of cells from those rare people who are immune to HIV because they have a genetic mutation called the Delta 32 CCR5 mutation. So now we have 5, basically, although one, Timothy Ray Brown, very sadly died a few years back. So we have 4 people living in the world who are officially regarded as having been cured. Next, please. So that really tells us a bit about the patient, the guy. There are interesting things. He received a milder conditioning regimen. Conditioning sounds like something you use on your hair. It is not. It is something nasty. It basically means that they effectively delete most of your immune system in order to enable you to have a bone marrow or stem cell transplant, which doesn't get rejected. He had mild graft versus host disease. That means what can happen because of rejection, but in the end, the new cells actually rejected the old cells, as it were, and that meant that he achieved 100% chimerism, which means replacement of home cells with transplanted immune cells. Okay, next slide, please. Right. Just before this, I'm going to slip in a couple of other things. No, one other thing. There was also one very interesting patient who's what we call a post-treatment controller, was presented. She was from Barcelona. She'd had an experimental treatment in the 1990s of immune boosters. They'd taken them of antiretrovirals, and she hadn't had to go back on them for years and years and years and years. And they may be people who are more achievable models of cure than people who have their entire T cells or immune systems deleted anyway. But the central problem with a cure is that we can't find the cells which HIV lurks in. And HIV infection is lifelong, because it literally gets inside the DNA, inside a tiny proportion of your immune cells. But like cancer cells, and I think a cure for HIV is going to be very like a cure for cancer, though it would have to be less toxic. Basically, any sort of imaginable cure involves either deleting the cells that have HIV in them or getting the genes out of them by some clever genetic therapy, or suppressing them so that they never, ever produce HIV again. The trouble is we've had no way to detect these reservoir cells up till now. And although it was tremendously technical, this presentation, lots of people read it, which is interesting, showing that they've developed a terribly clever assay, probably still quite expensive, where they sort people's immune cells out. They take a sample out of their body, they sort of stimulate it to sort of show whether it's got HIV in it. If it does, they shine a laser light on it, which picks out the HIV-infected cells, so you can tell how many of them there are. That's very impressive, but what's more impressive, that it enabled them to create, next slide. Next slide, please. This is just there because it's a pretty picture. But what it shows is that this is what they call a heat map of genes. In other words, which genes are active and which genes are unusually inactive, suppressed. And they found a very different pattern of activated genes in these reservoir cells that contain HIV. What that is exciting, because it does mean that in the future, you might be able to develop genetic therapies that target the specific markers that those cells have on them. And that's as far as I'm going to talk to you about cure, because it's always complicated. There was very little new about vaccines either, although lots and lots of experimental ones are still being looked at. Okay.
That's great. Thanks, Gus. I think we had a couple of questions come through. And just to say to everyone, the session has been recorded and we will be sharing the slides as well. One from Joe around talking about the tail of the medication. So essentially, when it comes to long-acting injectables, how long it lasts and whether it kind of stays within the body for longer in women than men. Is that the case?
Yes, amongst some women. It may depend on your genetic makeup and how quickly your body eliminates drugs. But certainly there were some early studies I read of injectable therapy, which show that when you stop the injections, there's still sort of, it can hang around your body for a year, extraordinarily long time. This is a problem if you are still continuing to be at risk of HIV, but aren't taking injections or oral therapy, because what that means is that you might get into the situation where you catch HIV while still having a bit of HIV drug in your body, and that is the conditions you need for resistance to arise. But there's been, and this did actually happen in a handful of cases, 4 or 5, I think, in the gave me a trial of injectable PrEP, but not amongst the women, interestingly. And obviously with cabotegravir, you don't want that to happen because it is an integrase inhibitor, and that's sort of the cornerstone of current HIV therapy, although you can construct regimens that work around it.
And can I maybe ask us about, so that's in the case of taking the injection for prevention. Mm-hmm. If someone was taking cabotegravir or rilpivirine for treatment and then for whatever reason dropped out of care, presumably that long tail could also be a problem in terms of resistance.
It would probably be more of a problem than all I have to say about that is that so far the injection studies, both off PrEP and off treatment, have shown very good adherence, that people generally, not a lot of them drop out. There were a couple of real life studies, i.e. In Glasgow, which showed that people had very rarely allowed more than a week or two, and you've probably got a week or two's grace to last after they'd had injections. In fact, more people were coming early than coming late.
That's interesting. I think that probably kind of speaks to what Roger was speaking about around how we've not seen these drugs being used in all different populations, so perhaps where people aren't housed and don't have their own home and that kind of thing, whether we see similar results in those populations. So definitely another reason why we'd like to see developments there. There's a couple more questions. One from Mina around any developments with long-acting HIV implants. I guess probably the update from Glasgow the other week probably alludes more to that than this conference, but if you want to share some of the latest on that, either of you.
Yeah, I mean, implants are obviously kind of a better thing than injections because you can take them out. And this gets away from the problem of once you get an injection, you're stuck with it, which Roger was bringing up. We had high hopes of a drug called islatravir, which was extraordinarily potent and long-lasting and could be put into an implant, just a little sort of spaghetti, like a bit of little polystyrene tube that you have on your skin. You could take it out. These are already used for contraceptives and antipsychotics, but islatravir turned out to have a rather toxic effect against CD4 cells, and so you don't want that. So they hastily went and looked to see other follow-up drugs. Gilead have a drug called lenacapavir, which you can probably take once every 6 months as an injection, and a smaller injection. You don't have to have a big injection in your bum. It can be given as a injection under the skin in the arm. There are new ones still being developed.
Yeah, it does feel to me that on the implant front, we were quite excited because of islatravir, and at the moment, it's I get the feeling that's where drug developers would like to go, but I'm not sure they're getting there right today. Yeah,
it was a big blow to Merck, the manufacturers. They admit it, and they do have drugs of the same class which are in early studies, but it's going to put back their plans by a year or two, I would have thought.
We've just got another question that's talking back to the Doxy-PEP trial. Was that taken in the usual way as it would be if you were diagnosed with like a bacterial infection? Was it kind of the 7 to 14 day period, or was the dosing different?
No, it was because as with PrEP for HIV, if you've got, but that's slightly different because you actually can get rid of these STIs from your body, whereas you can't with HIV. But as with a drug to prevent HIV, you don't have to take it all the time. As long as it's there at sufficiently high levels at the time you are at risk of HIV, then that's all you need to do, which is why event-driven HIV PrEP works. So all they said was, no, if you've been at risk, take a pill afterwards. The other studies have said take a pill before. But I think in this particular context, it's probably easier to take it afterwards if you have them around. And we're talking about, people just basically need these on their bathroom shelves if they've got bathrooms that have shelves. So, I mean, it may be useful for particular populations like gay and bisexual men, possibly if they're interested in doing it, female sex workers. I don't know about other populations, but basically, no. It's basically intended as a 1 pill PEP dose.
Thanks for clarifying. I don't know if we've got any last minute questions. We've got a couple of minutes left. It's been a really informative session. As I said, we will also share the recording and the slides for anyone that wants to see them afterwards as well. Okay, I don't think we've any more. In that case, Roger and Gus, thank you very much. So extremely well thought out digest of everything that came out of the conference, and thank you for presenting it clearly.
Okay, thank you, everybody.
Pleasure.
Thank you for the thank yous.
Thanks for your attention.
Yeah. Okay.